Hello, I'm Dr. Ross Hansen, Associate Editor for a Seminar in Cardiothoracic and Vascular Anesthesia. Today, I want to welcome our subscribers to a new video interview format. Building from our ongoing podcast series, this new multimedia interview format is designed to expand authors' ability to showcase their work as well as to enhance our subscribers' experience. As some of you know, we've become the home journal for the Society for the Advancement of Liver Transplant Anesthesia, or SATA, and our current issue is focused on topics surrounding solid organ transplant. Today, we have Dr. Michael Souter with us to discuss his article on organ donor management in our current June issue. Originally hailing from Scotland, Dr. Souter was recruited to join the faculty at the University of Washington in Seattle in 2001, where he currently serves as the Chief of Anesthesia at Harborview Medical Center. In addition to his clinical work with the University of Washington and Harborview, Dr. Souter is the Medical Director for Life Center Northwest, the organ procurement network for the Northwestern United States, and he served as the National Medical Advisor for the Association of Organ Procurement Organizations. Dr. Souter brings a wealth of knowledge and experience in solid organ transplantation to his current article entitled Organ Donor Management, Part 1, Towards a Consensus to Guide Anesthesia Services During Donation After Brain Death. This article represents a major step towards improving anesthetic practice. We're fortunate to have the opportunity to speak with you today, so thanks for taking the time, Dr. Souter.
Thank you and welcome, and I appreciate the invitation and the welcome you've given to me, so yeah, thanks.
So your article starts by describing kind of the current state of anesthesia literature as it relates to organ donor management in the peri-op period. Can you briefly expand on this and talk a little bit about why we seem to be lagging behind in organ transplantation specifically as a specialty?
So this article actually had its genesis in discussions some years back between various members of what can be referred to as the Organ Donation and Transplant Alliance, which was looking at opportunities to increase communication and education in and around the field of transplant medicine. And the organ procurement organizations, of which you've referred to, that I'm the medical director of one of them, one of the 58 in the US, many of their members actually attested to difficulties they had working with anesthesia in this environment and the challenges that they had trying to get people to display a consistent practice and consistent interest in this. And so that piqued my interest, and obviously as an anesthesiologist, I thought, well, hey, you know, we can do better in this regard. And I went back and looked at the literature, and you know, despite the fact that there's some seminal few papers on this, and I refer to some of the stuff that's been done by Adrian Gelb and others in the past, that dates from decades ago. And when you actually look at the literature, there's probably, at the time I looked, there was only about 16 articles, you know, in the anesthesia major journals referring to the concept of organ donation and physiologic support and management of organ donors at that time. And so it struck me that, you know, here's an opportunity here to try and redress that, to try and kind of bring this into the kind of modern day. And in the subsequent years, there's maybe been a couple of articles appeared, but really, you know, nothing, you know, that addresses what I perceived of as a gap in that area. And so I kind of enlisted the help of others, and between transplant surgeons, between intensivists, other anesthesiologists, and pediatricians, we actually got a nice collaborative effort going to actually produce something which we think will be of interest and support to the anesthesia community at large.
So for those anesthesiologists that are used to kind of thinking as these cases as less involved because the patient is a donor, I think that graft or allograft loss really seems to be the obvious consequence of suboptimal donor management. But in your article, you touch on a number of other less thought about implications for our management of the donors. Can you talk about some of these in brief?
Sure. I think one of the things we appreciate that, or rather fail to appreciate when we're got this challenge of, okay, we need to get this donor into what may be a busy operative day, is that we kind of think of it as a very elective circumstance. It's something that can wait. It's not an urgent uh, issue. And I think that perspective actually fails to take into account the major exercise in logistics that actually getting a coordinated procurement team together actually is. So just to give an example, in my own institution, which is a kind of level 1 trauma center, we fairly frequently get requests from the organ procurement organization. Can you, accommodate us to basically procure organs from this donor who you've had in your hospital, and we're now ready to do that. We're going to take the lungs, and the lungs are going to go, say, to Arizona. The heart's going to go locally. Kidneys may go to the other side of the state in Spokane, and liver's going to go to Pittsburgh. We may actually have all this coordinated, and multiple teams actually arriving at our hospital to kind of pull all this off with all the air traffic and everything else that's involved. When we don't facilitate that, when we fail to support it, or we kind of fail to negotiate some of the delays and inefficiencies which affect us on a daily basis, then we run the risk of taking all that carefully sequenced, choreographed moves of teams coming in and out, and actually it being thrown awry into chaos. And that happens too often. I think that if we also fail to support what we see as somebody who is, yes, legally they're dead, but their organs are still viable. And I think that if we're only partially or half-heartedly supporting physiologic targets of resuscitation for those organs, those directly translate into impacts upon recipients. We see recipients experiencing a higher incidence of delayed graft failure, which then translates into factors like increased dialysis, for kidneys, say, for example. We see that then again translate into length of stay, which impacts upon hospital margins. So there's a whole domino cascade of effects which can actually happen when we seemingly innocuously just can't get on top of managing an acute situation and trying to kind of pull off a procurement as efficiently as we might otherwise do.
So I think in that you touch on one of the key points, which is that some of these suboptimal donor management things that happened on the donor end actually translate into pretty serious clinical problems for the recipients. Do you think that's a fair statement?
Yeah, sure. I think that under resuscitation of organs in these circumstances really have material effects that we see in the dead as much as we may expect them in the living. We see a hypotensive, hypoxic patient experience a higher degree of ATN, and it makes eminent sense that if we've got an organ that's leaving its donor, but is previously primed to be inflamed and suboptimally resuscitated, then it adds to what is the obligate injury of the ischemia reperfusion that's taken from explantation and subsequent reimplantation into the recipient. But we're just making things worse if we fail to supply that kidney or that liver with adequate amounts of oxygen and nutrients beforehand. So yes, these things do translate into kind of very real consequences for recipients.
So I think that building on that, and one of the things you expand on in the article itself is that in addition to the operative management of these patients, we as intensivists also frequently managing them in the ICU certainly have the ability to care for them and optimize some of this too. Do you mind just talking a little bit about kind of some of the things you talk about in the article about the ICU care relevant to these patients prior to them coming down to the operating room, and how you kind of introduce this whole concept of a perioperative period for the donor?
Sure. When you think about it at its most basic, I mean, these are patients who are probably the most physiologically deranged that you will ever see. I regularly tell my fellows and my residents that if they can manage a donor in these circumstances, they should be able to do, resuscitate just about anybody in the living environment. These are patients who have had a primary injury that has devastated their brain in the first instance. They've had all the secondary iatrogenic consequences of the treatments that we've tried to effect in the donor to try and save their lives beforehand. The hypertonic saline, the dehydration with mannitol, the pressors that we use to escalate blood pressure up into kind of truly supraphysiologic levels. These are patients who may have already experienced hemorrhage and had multiple periods of resuscitation. They can be fluid depleted. So they've got all that whole host of physiologic events going on, that then death on top of that, the dying brain releasing cytokines, inflammatory products, those go down, they hit the lungs, they prime the lungs and the heart, and we see a higher incidence of organ failure in those circumstances. Those are all things that demand, I think, the most acute and well-guided resuscitative care in the ICU environment that you can pull off. Good care does translate what seems to be this kind of horrendous physiologic paradigm into something that you can actually see a positive outcome from in terms of organs that you can retrieve. I can look at a heart in somebody who is, wildly hypotensive, may only have an index of 1.6, 1.7, and needing large doses of catecholamine support. And I know that if I can nurse that heart through this acute period of dysfunction, it will recover, and it will recover to be able to be transplantable into recipients who otherwise may stand a very real chance of dying. For all of those organs, whether it be talking about heart, whether you're talking about lungs, whether you be talking about liver, kidneys, there's always this obligate period of dysfunction occasioned with the dying process that we can resuscitate people beyond. And there's a study by Niebauer back in 2011, which actually showed that for every hour you actually manage a patient after the declaration of death in the ICU, you can reduce the incidence of graft failure when that organ is actually implanted into the recipient, as long as that management is active and guided towards physiologic targets.
Oh, that makes a lot of sense. So I think that one of the things that's done very well in the article also is you kind of introduce this idea of a checklist to introduce some kind of goal-directed and specific resuscitation targets. So what I want to do for the viewers here is kind of pop that checklist up on the screen so everybody can see it. And then I want you to kind of go through and tell us, kind of just walk us through the checklist itself, just so people can kind of consider introducing this into their practice, okay? So you should be seeing that now. And if you just want to start at the top and kind of talk about the checklist, we'll kind of go from there.
Sure. I mean, there's just some straightforward logistics here, that because so often our challenges in the OR environment, whether we're talking about any patients, are communication and making sure that we know what we're dealing with. And so what this checklist is designed to do is to start off to get us all on the same page and to know that who we're dealing with. So height and weight matters. Height and weight matters considerably when we're talking about trying to kind of size lungs for recipients. Is this an organ that is actually going to fit physically into the recipient? Is it a liver that might have to be split? Are the lungs going to be too big? So just having kind of a good insight into that, these kind of demographics is really important. Getting the blood group right is a kind of pretty basic standard, but even just knowing the level of obesity that we might see in somebody, to be able to work at a BMI, body surface area, all those things are important, just in characterizing the environment that the donor organ came from. Making sure we've got a good quality brain death declaration is really important, making sure that's been followed through. So that's a tick box there, that the internal process that satisfies an appropriate declaration of death has actually been undertaken within that hospital, and that there's been authorization for donation in those circumstances. We then want to have everybody agreed on which organs we're talking about here. Sometimes, and it's happened with my own experience, that we've moved on to kind of say, okay, well, we're going to do lungs and the liver, and then the procurement team says, hang on, aren't we doing the kidneys as well, or aren't we doing the heart as well? So all of a sudden, finding out that there's a different set of goals to that which we've been aiming for previously is embarrassing, and we want to try and avoid that. So just having everybody informed up front, what exactly are we dealing with? What's the operative task ahead of us there with that? So that just sets the stage for knowing exactly what we're dealing with. Which organs are we talking about? What test results have we actually undertaken and done? So what's accessible for people to refer to? They want to come into the OR and know whether something's been done, and appropriately, whether or not something actually needs to be further investigated before we actually head into the points of no return in the procurement stage. Making sure, again, just more logistics. Have we got the OPO there? Knowing who the transplant coordinator is, how do we get hold of them? When's the OR booked for? These are just kind of common sense things, which it just helps to have a kind of aide memoire. The things like the level of catecholamines that are going are pretty important as well. I frequently had some instances with procurement surgeons when they've arrived and they've not known the fact that the patient was still on norepinephrine. And that has material consequences for how they view that organ and how they're willing to kind of think about it subsequently. And so, again, prior communication of where you are in these circumstances is really important. Knowing what kind of doses we're on, knowing what the ventilator settings are on. Are these lungs going to be usable if they're being ventilated at 20 mils per kilo, for example? Probably that might give rise to some concerns there. So again, just having that communicated and everybody knowing exactly what's happening. Having the blood products ordered is important because occasionally we still need to kind of give blood and correct coagulopathies in patients who may be experiencing still some pathologic derangements of coagulation as a consequence of their death process there with that, and making sure we've got the tools to hand. So it's this, a lot of this is just information gathering, presentation in a succinct and viable form so as to communicate as effectively as possible. And then we move on to the more intraoperative setting. What are the things we actually need to have? Have the team, as the anesthesia team, actually seen and reviewed the OPO protocol? Have they discussed anything that they're not clear with? Getting those kind of questions out of the way. Think of it analogous to the huddle that many of us now do at the start of the day, shown to be kind of good practice in terms of minimizing conflicts or any kind of unknowns about how an operative course is going to be. So we're using this really as a kind of tool to support and guide whatever huddle we need to have with the organ procurement team when they're actually coming in. They may ask for drugs which we're not used to giving. We may never have given patients intraoperative prostaglandins or buffer agents, TAM, or started T3 or T4 in this environment before. Yet those are things which actually have their place in structured protocols for organ resuscitation and care at the time of procurement. And again, just knowing the fact that we've got blood products there, when was the heparin given, how much was given, etc. When was the cross clamp actually applied to the aorta? Those kind of things are kind of important for us to know and communicate again. And then we've got the physiologic targets that we have, keeping blood pressure above a certain level, keeping heart rate into kind of a manageable range, making sure that we've actually got the CVP within kind of a recommended range, as well as pulse pressure variability or pulmonary artery pressure for using those. What are the recommended settings that we want to use for the ventilator? These are all just suggestions and guidelines, not designed to say you must do things this way, but these are good starting points to actually have that discussion with your procurement team and say, okay, this is what we propose to do, guys. You get any comments on this or anything else that we want to do to change this before we engage in this. There's a couple of things that are pretty unique to the procurement environment. Some of those is the requirement to actually use muscle paralysis. And that's not because the patient is aware of anything that's going on. We don't use opioids at all. We may use volatiles in order to obtun some of the hypertension that we see as a consequence of spinally mediated reflexes in this circumstance. But it's very common for us to see muscle paralysis, to see muscle responses in patients because of peripheral stimuli. Spinal reflexes happen probably somewhere of the order of about 40 to 45% of donors. They can be really disconcerting. That's not a sign that somebody is not brain dead, but it's just a sign that the spinal cord is still alive and actually somewhat disinhibited because of the absence of descending inhibition coming down from the brain itself that normally quiesces and controls spinal activity in this circumstance. So that's, again, that's something which people may not be used to seeing. I would also heartily encourage everybody, please, to not use starches, because we've got good evidence to show that that does not help the kidney at the time of procurement.
So I think that your article makes a strong case for the fact that we as anesthesiologists really need to systematically improve our practice when it comes to organ donation. From your experience and knowing the literature, how often do you think currently as a specialty we're meeting most of these goals that you put forward in your guidelines?
Like I said, talking to my colleagues in the OPO world, not often enough. I think that we've got islands of good practice. I think that there are academic centers where this is happening on a daily basis, and that people are interested, and they've got to build up good relationships with their transplant surgeons, and they know what it is they should be doing. I think for all of those situations, there's also a kind of wider hinterland out there, community hospitals, other smaller hospitals, where there's not a consistent relationship with a transplant team, where they don't know that that they have to undertake some of these goals and tasks that they have, and they may only be doing 1 or 2 procurements a year. And so you may, as an individual on call, perhaps only see one of these every 2 or 3 years. It doesn't really put you in a good basis for making a kind of the best practice possible in that particular situation. There's also been a little bit of as anesthesiologists, we see ourselves as very much being focused on the living, trying to resuscitate, save people. And I've actually seen this within the anesthesia literature. We don't want to be associated with a community of death. And I think that's entirely the wrong perspective to take in this. This death has already occurred, and we actually have to accept and honor the fact that through this death, the donor has actually chosen to try and give life to others. And if we don't do our very best to facilitate and support the quality by which those organs are procured, then we're diminishing the opportunities for sustained life in the recipients down the road.
Well, Dr. Souter, I think you make a really good case for all those things, and I think this is great work and a really interesting body of literature. And I think we'll be interested to see where things go. Thanks. Thank you very much for taking the time to talk to us today.
Thanks so much again for the invitation. I've enjoyed it.